Honor and pleasure to be here. I would like to thank our Greek collaborators and partners to make this actually happen, the simulation course, because it's really, it's a team effort. It would not be possible without all the incredible effort of the local partners. I also would like to thank the Society for the invitation and our host for this great time we had here together. So yesterday I was doing human factor, and now I'm supposed to talk about artificial intelligence. You might see there is a conflict there, but you will maybe understand why there is a big link. So you see it's the Pegasus, or it's a Trojan horse. So the artificial intelligence can be an utopia and a dystopia. That's why it might be also a Trojan horse. I have a conflict of interest to share with you, is that I actually coordinated a research consortium in France trying to develop a decision support tool for trauma care. So I have a big conflict of interest. My other conflict of interest was that I had total despair of my math teachers. Okay, despite working on artificial intelligence, I'm very terrible and bad in math. So I'm one of the dummies. Why is that important? Because I think it's really important that we as clinicians, I'm just a clinician as you, that we as clinicians, we stay in this process, okay? That we are part of the team in the cockpit to really, to make the research happen and to understand, is this useful for us? And so, yeah, they said, with your name, that's not possible that you're bad, but I was bad. Okay. So the plan for the outlay is, what is artificial intelligence? Because there's some confusion, so we have to understand what it is and what are the concepts behind. Why should we actually use this? Why it's interesting? What can it bring to us? Then we'll have some examples in trauma care, in the current literature, and then we'll provide some perspectives. So what is artificial intelligence? So it can be a lot of confusion, and it's actually a generic term. And it includes a lot of things that are not always the same. So artificial intelligence itself is to try to reproduce and make a computational algorithm or machine, let's say it, think or work like a living being. Can be an animal, can be a human being, can be some brain mimicking, okay? One of the methods to do this is machine learning. Machine learning is actually nothing else than complex math, and the math behind that is actually quite old sometimes. It's very astonishing to see that the math behind this is quite old, sometimes from the beginning of the 20th century. Deep learning then is something you really try to imitate the brain, the way it works. What is data science? Data science is to make this happen. You can have no artificial intelligence or machine learning without the people who make the data workable, accessible, to clean up the data. And this is really science. There's a lot of work behind that and expertise. Artificial intelligence is also anything but artificial, because the data has to come from somewhere. Somebody has to go and dig up the data, okay? The data, we don't live in the cloud. Somebody creates the cloud. Somebody puts the data into the computer. Most of the time, actually, humans put the data into the computer. So there's really human resource behind the data that is accessible. So there's nothing artificial. There's a physical process behind creating the data. And these data, they're not always workable. They're not always processable. They need a lot of processing to make them usable. So we'll see that in a moment. So there's nothing artificial. This is real life. This is what you do. This is the patient measurements you take in ICU, in the pre-hospital area. It's the administration data. This is real life. This is physical. It's nothing artificial. And it's nothing but intelligent. But for the time being, we really rely still on a lot of expertise, of human expertise, to make this data usable and accessible. And with anything in research, it's really what you put in, you get it out, okay? So enabling the data, empowering the data to talk to us, to make them usable and workable, is actually the big first part of any use in artificial intelligence. There's no magic putting the data into a box, shaking it, and then have an output. This is not how it works now, and I'm pretty confident this is not how it will work. Okay, so to take one example, for example, IBM had the oncology artificial intelligence system to assist decision support in oncology, Watson, all right, and it was a total mess. It was really a huge investment, was deployed over hundreds of hospitals over the world, a huge investment, and it was crap, probably because the enabling of the data was not done well. Garbage in, garbage out. Why as clinicians should we be interested in data science? Why could that actually end artificial intelligence? What could this bring to us? So in an utopia, you could have, it's very, and I really relate to what Ryman said, is to use this data to individualize as much as possible our therapeutic and diagnostic approach to every of our patients. So you could imagine you could map like all these information from one patient and have a smart neural network, a deep network that processes data, and it gives us the perfect information, maybe even preemptive or preventive, and telling us what we need to do with this patient. And you can see you can include family history, you can include genetic information, environment information, socioeconomic information, so like a mapping or cartography, like real life, online, ongoing, to prevent and to have actually health incentives or health intervention before the disease happens. Okay, that's the utopia. And you could then bring all this into a lifelong pathway, like a artificial intelligence pathway that for the patient. So to understand why this is possible, it's what made this happen. Well, it's the data revolution. The data revolution is nothing about math. As I told you, the math is quite old. It's just our capacity to process data, okay, which has exploded, like literally. To give you an idea, so you see the pyramid of gigabytes, terabytes, etc. So let's look at something that we know, our genome, or Ziggy Stardust from David Bowie. This corresponds about to 1 megabyte, okay? So you fit onto a CD from Ziggy Stardust. When I showed this to my kids, they said, "Dad, nobody listens to a CD anymore." Well, but that's, as you can see, things evolve really quickly. When you stream a film on Netflix, it's 1 gigabyte, okay? So imagine the millions of people who watch Netflix at the same time. So just to give you an idea of the amount of data we're able to process. And then the capacity to process and compute them quickly. 1997, Deep Blue, IBM, was beating a grandmaster in chess. That's the number of operations was able to provide and to process. 2015, AlphaGo, Go, a much more complex game, many more dimensions, many more computation, and that's the number of operations the AlphaGo was able to process from Google. And that's the number of atoms in the universe, okay? Just to give you an idea. So it's huge. But it's not because I'm able to compute a lot of things, that is what I compute is pertinent, relevant, or useful, all right? So, quickly, what kind of methods do we have? We have supervised learning. Is that what you actually know? It's like regression is a form of supervised learning. You have expert input, and the machine will provide you an information. You have, for example, in this example, you have a lot of cats. It will learn to recognize the cats. You give them new data, it will recognize the cats. Unsupervised learning, if you give, it's that the machine learns on itself. You have a group of animals, and the machine will learn to detect patterns, and this pattern will be the cat, and then it will find all the cats within the animals. Unsupervised learning. Reinforcement learning is something that is more close to what we actually do and how we learn as human beings. In medicine, we learn a lot with reinforcement learning, meaning that we create neural networks that will reward us for what we do and tell us this was a good action. And the computer can do the same with data and the computer. For example, for vasopressor administration, very nice work from Mathieu from London as an example of reinforcement learning in ICU. So this was quickly about the concept. So why should we deal with this? Why should we have a look at this? Because we're humans, okay? And here you see the link to what we did yesterday and the day before in the simulation, is because we're humans. So we're able to do the best and the worst. We're able to perform really well, but when we're tired and when we're exhausted, we had a fight with our partner, whatever. We are not reliable, okay? We're not reproducible. The idea of medicine is also to provide standardized care and to make this happen by design and not by chance. So we as human beings, we supply the fact that we're human, we supply a level of chance. The machine is never tired. The machine is never angry. The machine is never hungry. So it's always reliable. So if you want an output, then the machine will always provide the same time, at the same time, no matter the time of the day, etc., etc. So the idea is to make decisions more reliable and reproducible, and to reduce at the same time our cognitive load. Maybe the machine can do stuff that they can perform much better and quicker, and that are more repetitive, that we are less able to provide and provide reliably. So it will reduce our cognitive load and our workload. The question is, and we have no answers, that is the machine, are they as well adapted to deal with complexity and uncertainty, or the known unknowns as Donald Rumsfeld said a long time ago, because it's possible, and some psychologists are quite convinced that the biases we have is actually our evolutionary mechanism to adapt to uncertainty, and that's very powerful, and that maybe the machines, they have the same struggle to deal with uncertainty, but we have to find out. So now actually with this spoiler, or with this introduction, let's talk about examples in trauma research. So right from the start I have to disappoint you, because that's the level of research currently in artificial intelligence or machine learning in critical care. So this is a great review in ESICM. And you can see we have a lot of models. So the explosion of data science and the capacity to compute created an explosion of models, all right? But as you can see, we don't have a lot of clinical application. All right. So we have currently, and that's really the problem of the field, is that lots of ideas, lots of models, they don't even very often validated or validated in an external setting. And you see, this is the desired movement we should have. Okay, we should go from here, from the model to the validation, real-time testing, integration into a workflow, and clinical outcome evaluation. And for the time being, we're not there. All right. What kind of examples do we have? What are promising paths? So first of all, of course, as I said, this is perfect to provide classifications, stratifications. So for example, Raymond spoke about individualized or heterogeneity of TBI. Well, that's perfect. You could use artificial intelligence to create new classifications, stratifications. For example, my group's been working on new classification based on artificial intelligence to classify TBI, so that we can better then in future studies target the therapy or better choose the outcome. Image analysis, very strong. This will definitely come. Any kind of prediction tool, so prediction to support decision, or prediction, or try and prove the best strategy. Causal inference. Causal inference is, let's say, observational studies 2.0. So it's more targeted and more precise and more reliable methods to really identify a causal association between predictive factors and an outcome. And this can be really useful to prepare randomized controlled trials, to have a better targeting of your population and in your cohorts. So causal inference to improve our observational studies. Closed loop administration, I already spoke about vasopressor, so there's a few very interesting works about closed loop vasopressor administration or ventilator optimization, and complex signals, physiologic signals. The things that we will focus on quickly is image analysis. Image analysis, this will definitely come, okay? There are lots of applications out there, and they get better and better. So this will definitely come. We will have automated image analysis, in particular for trauma and traumatic brain injury. We'll have decision support. So here's a great example, a recent example from Japan, where they used machine learning to predict, based on pre-hospital data, the likelihood that this patient will have an intracranial hemorrhage after traumatic brain injury, with, as you can see, a rather satisfying predictive performance. And curious, interesting in this, they haven't compared it to the physician prediction, because you can see an AUC of 0.8 is not so great, so it would have been interesting to compare. But this will definitely come, okay? And it's also a way to streamline triage and patient orientation. Interesting so far, and I think that's very promising pathway, but so for the time being, no clinical application tested prospectively on patient outcome, is processing of complex physiology data, like heart rate variability. This is work from 2014 already, from colleagues from the US. So this could be really interesting, predict physiological outcome and use complex physiological data for patient outcome and target interventions in trauma, for example. And as I said, work from our group is to identify best strategies. So here we did on our national registry, we tested bundles of care for shock and traumatic brain injury, and then looked with the machine learning algorithm what is the outcome in 7 days, and we targeted bundles, we identified bundles that would reduce potentially the outcome, the mortality at 7 days. So ideal machine learning to find the best strategy to test, to treat our patients. perspectives. So one perspective I'm working on is, as I said, decision support. And why we are a bit ahead with our group is because we have validated the models. So one to predict the probability of shock, one for necessity to go to the neurosurgery or neuro ICU. And we're working on all the resources to predict the need to admission for a trauma center. We have validated the models in our group, and now we will engage in 2 prospective trials where we challenge the model against the clinician prediction. And we will then, in a second step, really integrate this into a workflow and see how this improves or affects triage. So really this is just to say that the crucial step, and what we have to be really aware about every time we face something about artificial intelligence or data science, is there's no replacement to the scientific method, okay? So any work in artificial intelligence has to have a standard, a sound clinical hypothesis, and should be based on patient-centered outcome and should be tested prospectively, so that we can really, as you can see, that we can go back on the dilemma we have currently, where we have tons of models, tons of capacities, but only promises and no results. So in a conclusion, it will come, and we as clinicians, we have to be engaged in this process. We have to stay in the cockpit to pilot this process. We cannot stay on the sidelines and leave this to the very, sometimes powerful economic incentives. Basically, you have the 3 tools that are mainstay, but this will evolve. This is a field that evolves really quickly. Even the experts I work with, sometimes they say this goes so quickly you can't follow, but you have supervised, non-supervised, and reinforcement learning. These are the applications, and in particular imaging and decision support and treatment of physiological data will be, I think, interesting pathways to follow up, but there's no replacement to the scientific approach, and we should just keep very, very aware and vigilant and maintain our standard scientific approach, and there's no magic with artificial intelligence. Thank you for your attention.
Thank you very much for the excellent talk. Thank you.